Good morning, everybody. We're going to get started. I know people are trickling in, but we've got a pretty tight agenda this morning. So we'll get started, and hopefully we can keep on time. So welcome to everybody in the room, and thank you, day 4, 7 a.m. I know it's tough, so we really appreciate you being here. And also for the people online. We have a number that have joined us online. So thank you very, very much. Today we're going to focus on maternal micronutrient supplementation, and in particular multiple micronutrient supplements. And as we do this, we ask ourselves, do we learn from history or repeat the same mistakes? My name is Jennifer Busch-Hallen, and I'm the Practice Area Director for Maternal and Newborn Health at Nutrition International. Given it's so early, I was thinking, how do we get energized for this session? So don't get too comfortable, because I want you to wake up. We have coffee and tea over there, so please get up and help yourself. I think there's a few little snacks there too. I want you to think about, I don't know how many of you were around in 2008, but stand up if you remember the Lancet series that was published in 2008 on maternal and child undernutrition. So this was a landmark series that really had a lot of interest. Don't sit down. I want you to stay standing because I have another question for you. Stay standing if you remember when the next series came out in 2013 on maternal and child nutrition. Great. And then stay standing if you remember the last one, which was 2021. Great. Don't stand up. Don't sit down. Don't sit down. You're only allowed. Stay standing. Think about where you work or the country that you support. Now I want you to think about iron and folic acid supplementation for pregnant women. And in your context where you work, stay standing if you have a coverage of more than 80% of women receiving iron and folic acid and consuming. So for people online, I don't know if you're sitting up and standing down, but we have nobody standing in the room. And I think what this says is we have a massive unfinished agenda in nutrition. Those 3 series were wonderful in telling us what are the proven nutrition interventions that we need to take to scale to move the needle on nutrition and accelerate global targets. But yet we're not there. We have a long way to go with program effectiveness and achieving what we set out to do. So over the next hour, we're going to learn a little bit more about what we need to do and maybe how we can do things better. We're going to take you through a number of presentations with a big focus on MMS, particularly in Pakistan and Nigeria. We're going to hear voices from the field in how do you actually get MMS into routine programs. We're going to hear from the government of Pakistan about the winding road and how to navigate this and the complexities that go with it. We're going to do a bit of a deep dive on MMS implementation research in Pakistan and also learn about some work that's happening in Nigeria. And then look at the value of evaluation in taking those learnings and then potentially how we're going to translate them. And we're going to hear from one of our key funders who are very committed to this agenda, and then share some of the tools that we have that might help you in this journey. When you came in, there was also some resources there that please, we don't want to take them back with us, so take them, take extra copies if you like for your colleagues. So now I have the pleasure to introduce the co-moderator of this session, Dr. Shabina Raza. She's our Nutrition International Country Director in Pakistan. I think you'll see how amazing she is in the bio in your program. But she's truly an inspiration, a leader and mentor for many of us, including myself. And it's an absolute honor to be able to co-moderate with Dr. Shabina. So over to you, Dr. Shabina.
Thank you, Jenny, for that lovely introduction and background about myself and the session today. A very good morning. I'm very pleased, all of you joining us so early in the morning. This is something commendable, showing the commitment that each one of you have for the mothers of the world. I just want to share that I've been in the field now exactly 40 years. When I graduated as a medical doctor, I wanted to work with children as a pediatrician. And I say what the situation in the country was working with children and mothers till over the last, from 1983 to 2023. What has been happening in the country globally, but specifically in Pakistan. Like we heard Jenny say, there's much more yet to happen for these vulnerable mothers. This conference, many sessions around MMS and the importance. Similarly in Pakistan, the government had decided to switch and try from IFA to MMS. And that was when we at Nutrition International came forward to help and support the government to actually take forward the implementation research, and a project was envisaged which we called Advancing Maternal Health through MMS implementation research in Pakistan. And the acronym which came out amazingly was AMI. AMI stands for a mother. And here we were interacting with pregnant mothers. We thought, what a suitable name for this project, AMI. So you can see that the purpose basically here again, we wanted to help them come up with identify evidence-based effective implementation solutions so that they could scale up in a sustainable manner. And the intervention here was specifically delivering the MMS through the platform of antenatal care for pregnant women in the public health system specifically. In a district, Sawabi, which was close to where the headquarters of Pakistan, Islamabad is, and I had the experience of working in that district as well. The district is a 1.6 million population, mostly rural, 83%. Literacy rate is, adult literacy is 46. I think female literacy would be 25%. And knowing all this was important because for all the interventions that we wanted to take forward in order to bring a behavioral change and improve upon utilization of services. So the project timeline was three years, and the key partners here, besides the government of Pakistan, was that we put together a technical working group for MMS, where key stakeholders who were interested in bringing MMS into the health delivery system in the government of Pakistan, which were the UN organizations besides ourselves, led by the government. And this was funded by the government of Canada. So if I can just tell you a little bit about the project very briefly, it was envisaged in 3 phases. We went in a phase manner. So the first phase, we did a situation analysis with formative research, and then we selected the key implementation research questions through the Chinri method. We'll be hearing from our next speakers in the session. And then in the phase 2, it was a participatory design phase where qualitative research was done to develop enhanced implementation approaches through using trials for improved practices, tips. So you will be hearing more from our speaker in the session. And the third phase was evaluation phase. And that is where we are presently, where we're doing an outcome evaluation and specifically looking at adherence to MMS. And then evaluation of the whole implementation process and the cost effectiveness evaluation as well. So that is just giving an overview of what the implementation research looked like. But I'd also like to say the effort behind all this was starting engaging with the ministries at the federal, provincial, and district level, because there are 3 tiers. And Nutrition International had to put in a lot of work to get MOUs signed in order to know each party's responsibilities and roles and how to move forward to make it very systematic. And so all that took quite a bit of time. Then we had to import the MMS. So working through UNICEF, we got all the MMS tablets. We had to calculate, do the calculations of how much would be required during this pilot phase. And then making sure that we are engaged at the district level in the public health system as it was existing, to use the same system and then to identify the gaps and come up with a transition package, which would be an improved package from what was existing. So it took quite a bit of detailed efforts and from our teams in the field. So I'm going to stop there and ask the government representative. Oh, first I like to, yeah, thank you, I'm being reminded. I have a small clip, a video, which we made in Sawabi, and this will show you the mothers in Sawabi. So can I please have the video, and just to share with you, because it's important for you to actually visualize what the setting is and how the mothers felt about this implementation research project in the district of Sawabi. So please, can I have the video?
زمون کو ته لیډي هیلث ورکر راغله هغه ماته وی چې په هسپتال کې پری ګولۍ ورکړي د طاقت لپاره د ناجوړو ښځو چې په دې وجه زه رالم د هغې په وینا دلته هسپتال ته.
जैसे कि आपको पता है कि अनफॉर्चुनेटली पाकिस्तान में मैटरनल मेल न्यूट्रिशन के साथ साथ न्यूनेटल मोर्टेलिटी का रेट बहुत ज़्यादा है, तो ये बहुत ज़रूरी है कि हम माओं की सेहत को और न्यूट्रिशन को फोकस करें, ताकि हम न सिर्फ ये कि ओवरऑल मेल न्यूट्रिशन को बेहतर कर सकें, बल्कि जो हमारे प्रेगनेंसी आउटकम्स हैं जिसमें न्यूनेटल मोर्टेलिटी है उसमें भी बेहतरी लेके आ सकें. WHO ने ये रिकमेंड किया है कि जब आप MMS को लॉन्च करें तो उसकी पहले एक इम्प्लीमेंटेशन रिसर्च देखें, जिससे आपको ये पता लगे कि ओवरऑल इसकी यूटिलाइजेशन, इसकी एक्सेप्टेबिलिटी, कंप्लायंस और सस्टेनेबिलिटी के अंदर क्या इश्यूज आते हैं और उनको हम कैसे एड्रेस कर सकते हैं.
Well, it's a human-centered design. What we mean by this is that women are at the center of whatever we're doing at the moment in this project. It's their care, their well-being, that's the core principle of this project. The focus is actually to give them respectful care as part of their ANC.
په تصویرانو په یا کوم دا غي باقاعده ته تصویرانو خودل چې دا به داسې خوري او مال پورا چې کوم مطلب او ماته دا مو چې لکه دې وخت تاسو نه سومه نشته او دې ماته وی چې لکه په دې دا طاقت ګولې دي دا واخله په دې زه پوهه کوم پورا چې دا MMS ګولې دي دا واخله او په دې زه پورا پوهه کوم چې دا به تاسو څنګه خورئ او څنګه به استعمالوئ.
हामला ख़वातीन में ग़ज़ाई कमी को पूरा करना इंतहाई ज़रूरी है. आपने कोई भी नया प्रोजेक्ट किसी सोसाइटी में या कम्युनिटी में इंट्रोड्यूस करना होता है तो काउंसलिंग उसका मेजर कंपोनेंट है. न्यूट्रिशन इंटरनेशनल के हम बहुत थैंकफुल हैं, बहुत मशकूर हैं कि उन्होंने जो लास्ट ईयर जो हमें ट्रेनिंग एज ए डिस्ट्रिक्ट मास्टर ट्रेनर MMS टैबलेट्स पे दी है, वही ट्रेनिंग, वही नॉलेज और वही जो मेथडोलॉजीज़ हैं या टेक्निक्स हैं मैं अपनी लेडी हेल्थ वर्कर्स, लेडी हेल्थ विजिटर और लेडी हेल्थ सुपरवाइजर को देती हूँ वक्तन फ़वक्तन, जिसकी वजह से उनकी भी नॉलेज में भी इजाफा होता है और उनको भी आगे जो कम्युनिटी में पेशेंट को इंगेज करने या हमें रेफ़र करने में रिगार्डिंग प्रेग्नेंट लेडीज़, उनको भी ये इसमें हेल्पफुल रहता है.
دینه مخکې موږ سره آیرن فولیک ایسډ ټیبلټس هغه به موږ پیشنټس ته ورکول. نو اوس د هغې نه علاوه موږ له نیوټریشن انټرنیشنل په دغه باندې MMS باندې ټریننګ راکړو. نو اوس موږ د کوم پریګننټ لیډي چې موږ سره راځي نو هغوی ته موږ په دې باندې کاونسلینګ کوو او MMS ورته ورکوو. د MMS باره کې موږ خلکو ته دا پیغام ورکول غواړو چې د MMS دی کوم استعمالوي نو دې سره په دې کې د انیمیا کمې مطلب هغې چانسز کمیږي. دې سره د لو برث ویټ کم چانسز چې دي نو هغه کمیږي. لو یا کوم پریمیچور بیبي پیدا کیږي د هغې چانسز کمیږي. نو د دې لپاره دا ډېر ښه شی دی چې MMS دی استعمال کړي.
I am from District Swabi, and where we are standing at the moment, this is my village. So it's really good to see this kind of work being done in my district. We're not only targeting the pregnant women, we're actually targeting all the stakeholders, right from the healthcare providers to the pregnant women themselves and all the key influencers in their household, be it their husbands, their mothers-in-law or community leaders.
I hope this gave you a flavor of, I know you had to look at the translations, but this is exactly how it is. And much like project by the government in the district, and they were taking keen interest. So I'm going to invite the representative from Pakistan, the government, National Coordinator in Nutrition at the Federal Ministry, Dr. Khwaja Masood Ahmed, to come and share their version of, aspiration of moving from IFA to MMS in the country and all the challenges that they had to go and overcome. But the importance of government ownership comes across very evidently, because nothing can be done without the ownership and the leadership of the government. So over to you, Dr. Khwaja. Yes,
Thank you very much. And good morning, colleagues. Thank you, Jenny, for introducing and asking the people about the history of IFA. And when we started IFA in the 90s in Pakistan through the community health workers, which are called LHW, the initial response was really very encouraging. And I think the best we were able to achieve was around 60-65%. It was 90s. But then multiple things came up and it's all history. So I will take you through some of the efforts that government of Pakistan is doing for the last few years to replace IFA with MMS. And yesterday I was talking about in another symposia that the moment we heard that WHO has now allowed or has sort of recommended the use of MMS after implementation research, though we had already planned for IFA for the nutritional programming in Pakistan, we immediately switched to MMS and then requested NI for implementation research. A bit of background. Islamic Republic of Pakistan, with a population of around 255 million, 241 million does not include a couple of areas. Low birth weight, 22%. Neonatal mortality, unfortunately, is one of the highest in the world, and this is one of the main reasons of focusing the maternal malnutrition for the last 4 to 5 years, which was, of course, an area which was neglected not only by Pakistan but I think globally. Infant mortality has come down from 86 to 62% in the last decade or so. Now this picture shows the situation of maternal malnutrition, and you can see the long bars, the high mountains showing different micronutrient deficiencies, almost all, but specifically vitamin D, iron and zinc. In the last decade, WRA anemia came down from 50% to 41% due to some of the effort. Vitamin D deficiency, unfortunately, remained very high, and there are multiple reasons. Food insecurity is another area which Pakistan is facing, and you might be knowing that Pakistan is one of those very few countries, it is said top 10 countries, who are most affected by the climate change, which has heat waves, droughts, floods every now and then. And the floods that we had last year were so devastating that even the UN Secretary General had to come to Pakistan to see the status. This is just the another sort of representation of the maternal. There is another issue with Pakistan also. We are now facing the triple burden. Apart from undernutrition, micronutrient malnutrition, there is another challenge coming up, which is overweight and obesity. And it's specifically higher among women due to multiple reasons, including lack of physical activity and the use of processed food. Let me tell you something about how we shifted from IFA to maternal the multiple micronutrient supplements. In 2019, the Prime Minister directed the Ministry of Health to prepare a comprehensive nutrition programming using the life cycle approach, including all the stages and specifically focusing on the malnutrition of children and mothers, women. And we were developing that program, and it was almost complete, and the process of approval started that we received these WHO guidelines, and the ministry proposed we had a national health task force under the leadership of the Prime Minister. So we requested them that we want to modify the program and we want to change from IFA to MMS, and it was approved. So we immediately not only included that, but we also started developing the maternal malnutrition maternal nutrition strategy, which started in late 2021, and then we launched it last year. So that strategy now has a policy of Government of Pakistan that we will be replacing IFA throughout the country with MMS, and the process has already started with the support of different donors, donations, as well as through the indigenous resources by the different government. Definitely, it's not very simple. Yesterday I was hearing that we have the same service delivery structure available, but definitely it is not as simple as it appears. We know that IFA has not been very successful, and there were multiple reasons, but there were some advantages of MMS also, because the private sector has been using different formulation of multi-micronutrient supplements for multiple decades also. So there is a sort of advantage which is already there in the minds of the women that, okay, these multiple micronutrient supplements are better than IFA. So this was an advantage, but we definitely are using the same service delivery structure that we have in the public sector, but also targeting the private sector. Just before developing the maternal nutrition strategy, we also carried out IFA bottleneck analysis to find out what were the major reasons that led to the unsuccessful IFA utilization, and there are some of the findings which are almost the same throughout different LMIC. Supply chain and distribution challenges, then procurement gaps, sometimes due to delay in the procurement, sometimes due to non-availability of resources, and then storekeeping, distribution issues, and of course, we were unable to continue about the communication or the awareness creation among the for IFA in the generations who are coming up. These are the WHO guidelines requesting or directing the countries to look at their context. So there are a lot of ifs and buts in these guidelines. But when I asked WHO senior colleagues in the Eastern Mediterranean region, he said these ifs or buts are for the country to decide what they want to do. So that's what we decided, that, okay, we will go for switch and we will start with the implementation research immediately, and simultaneously we switched also. So these are some of the guidance. Implementation research was the basic direction or the guidance by WHO. We started, as Dr. Shabina has already mentioned, in late 2020-21, and it got a bit delayed. I mean, we were expecting it to be completed maybe by the end of this year, but the evaluation process is still going on. But anyhow, on one side, this implementation research is going on, which will be looking at feasibility, acceptability, sustainability, and of course, cost effectiveness, as well as the equity among the, and you must have seen the picture of or the video. It has mostly rural background, poor population, but also the urban setting. So equity is more important than accessing the women overall. For scale up, we had to ensure that the supply is of good quality, then there is a monitoring system in place, and it is, I mean, this was one of the province. You must have seen the local language also. We have 4 different provinces and 3 regions, and every province has its own socio-cultural and background as well as taboos, so we will have to take care of all these things. So this implementation research will guide us through that, and it would also guide us how we can engage the communities and especially the private sector and other stakeholders. We are also simultaneously started working on local manufacturing or availability locally by the local pharmaceutical companies importing globally. Technical working group, Dr. Shabina talked about it. I will not go into the detail. There were some questions that we had to take care or we had to see before we were shifting the transition cost. Of course, the same health service delivery structure, only the cost of the product. Then introduction, I already mentioned some of the advantages. It was an opportunity for us also to strengthen ANC. The directions that our strategy gives is that in spite of supplementation within the community, the supplementation would be linked to the antenatal visits, and the pregnant lady would have to come to the health facility at least for the first time. But of course, this would, then it depends upon the healthcare provider to motivate the lady to come back again and at least have those 4 visits. And of course, the end goal was to consume MMS. I was talking about the floods. The red area is the area which was affected by floods, almost 30 to 35 million population, which was mainly inundated with water, and the water stayed there. Actually, this flood was very unusual for Pakistan. Usually we have floods coming from the melting of water from the mountains, and it passes away, destroying everything. But this time we had very high rains, and the water was stagnant in the lower plateau, or what should I say. The rivers were higher than the water, so water stayed for almost 6 to 8 months, and the people kept on displaced, and we had a lot of issues. So for this emergency area, humanitarian needs, we got this donation from Humanitarian, which has been distributed to 64 districts. And we have used some of the findings of the initial findings of the implementation research. I think it's almost end. Yes. Just let me, before I go to the way forward, let me tell you a few other things which we are simultaneously doing. It is an important thing. While we were doing the implementation research, we had IFA BNA findings with us. So we piloted simultaneously in few districts throughout the country to see whether we can use the IFA BNA to improve the uptake and utilization of MMS. And as I mentioned, due to that perception that MMS is a better supplement than IFA, we got very good results, very few dropouts, almost negligible refusals. But because it was just a pilot, we could not continue monitoring more than 6 months. But of course, there was a good example that this can be used. We were waiting for MMSIR, then this humanitarian crisis came up, and we got a good donation from Kirkland. It was almost 1 million bottles which were distributed. The way forward is definitely, we do have some challenges about local resource availability and all these things, but still the government of Pakistan is committed to scale it up, and in spite of all these challenges, we have a coordination structures at place at the national level and then going down to the provinces. And this is all. Thank you.
Thank you. Thank you, Dr. Khwaja. So it's good to hear from what we say the horse's mouth, you know, exactly what has been happening within the government and how they've been going forward on the agenda of the switching and upscaling from IFA to MMS. So my next speaker, who I'm going to invite, is Sarah Rowe, who's a technical advisor on maternal newborn health and nutrition at Nutrition International for the last 12 years, however, has remained in the field for more than 20 years. Her presentation is going to be around putting women at the center of research, and she draws her examples from MMS pilot projects in Nigeria and Pakistan. Sarah, please.
Thank you, Dr. Shabina. Good morning, everyone. I wanted to first take a moment just to acknowledge that the work that I'm going to present today is the work of many. It's the work of the governments that we work alongside, it's the work of the research and implementing partners, and it's the work of my Nutrition International colleagues around the world. I think you've heard and you've seen from some of the visuals that by design, the AMI project in Pakistan and a similar project that's happening in Nigeria first involves establishing MMS as the new standard of care. When women go to antenatal care through the public system, in the district of Swabi, for example, they're offered MMS instead of IFA. And it's no small task making this switchover happen. It involves intense training, it involves setting up monitoring systems, ensuring the supply chain is in place, having routine monitoring and supportive supervision in place, but essentially establishing this as a standard of care so then we can go deeper and actually look at some of the implementation research questions of interest. And it's this research that I'm going to speak a little bit about today. So what you have on the screen, I'm not going to go into great detail here, but it's showing some data from the Nigerian Demographic Health Survey on the far right-hand side. You can see in the green bar the receipt of IFA supplements for pregnant women in their last pregnancy. It's hovering around 70%. But then if you look at consumption of at least 90, it's sitting at around 30%. And it's the stark difference between the receipt of what women are getting at ANC versus actually what they're consuming that we call the adherence gap. And it presents a real missed opportunity for maternal nutrition. The concern is that if countries merely switch over from IFA to MMS on the existing ANC platform, are they going to inherit the same problems? And are they going to risk seeing these same results? But there is a flip side to this. And as a new commodity, MMS presents an opportunity and perhaps the stimulus to do things a little bit differently for maternal nutrition. The goal of this research is to see if we can find some solutions to come up to answer some of these persistent implementation questions and problems that are really reducing the ability for the programming to have these improved pregnancy and birth outcomes. It probably goes without saying, and you heard in the video from my colleague Kuma, that these solutions have to work for the humans that are involved and are implicated. So fundamentally, this is the women who are being asked to take MMS every day. It's for their influencers, in the case of Pakistan, mother-in-laws and husbands, their healthcare providers, their communities, and their governments at all levels. And these voices serve as the backbone of this research project. I'm going to pull two examples of this. The first one is from phase 1 of the research project in the selection of the research questions, And the second is from phase 2 of the research project, where we looked at co-creating adherence solutions. So in phase 1, together with the government of Pakistan, we undertook a participatory approach to try and figure out what were the most relevant research questions that they needed answered in order to inform their scale-up. A modified Chinri process was used, and this involved 3 main steps: identification of all the possible research questions of interest, prioritization of these research questions, and then selection for the purpose of this particular study. For the identification, we worked with the core technical working group, which was mentioned by both Dr. Shabina and Dr. Khawaja, and we used the bottleneck analysis. Dr. Khawaja presented some of the results, and that really gave us a lifting off point to look at what were some of the implementation challenges, and then what were we really asked the technical working group to start to think through what are some of the opportunities or some of the solutions to those challenges. From that, and I translated the information into a set of implementation research questions. The initial long list was at 88, and this was consolidated through removing duplicates, et cetera, to a set of 28 implementation research questions. The next step was prioritization. We then worked with the extended technical working group, which includes representatives from all of the provinces, and includes many key stakeholders as well, to grade the 28 questions that came forward based on a set of research criteria. And I remind you again, we were looking for research questions that were really going to help to guide and inform the scale-up of MMS in Pakistan. So they were asked to grade on a set of criteria, including relevancy, acceptability, maximizing impact, informing policy and practice, and reducing inequity. This is a very busy slide, but I just wanted to point out that from those, we were able to generate these research prioritization scores and rank the different questions accordingly. The other thing you'll see here too is that we assigned domains to each of the research questions, and we were very interested when we saw what came back. You can see here that what features really in that top 10 of the implementation research questions are questions that relate to things like delivery and service provision, capacity building, behavior change, and interpersonal counseling. While things like monitoring, supply, and anemia treatment are certainly an important thing and are up here in our top 28, they didn't feature in the top 10. This here is a knowledge product that we've made available to the government of Pakistan so that they can use it for further research if they want to investigate some of these other research questions. From that top 10, there was a selection of the primary research questions, and this is really where we landed. And it was the first question, which is, what implementation approaches could be used to strengthen the delivery of ANC and introduce MMS? And then, does the implementation of these enhanced approaches actually increase pregnant women's adherence to MMS? And if so, how? And you'll notice there's an important asterisk here because there's many aspects of implementation approaches we could look at. But really guided by that Chinri process, the areas that we focused on and are continuing to focus on in the evaluations are related to capacity building and supportive supervision of the healthcare providers, really looking at improving the nutrition content, counseling, tools, and techniques, and engaging the pregnant women's family members in the antenatal care. There's also a series of secondary research questions, but I'm going to leave those for another time. We're happy to discuss those later. So the different research questions involve have different research designs. And we really needed a participatory design to help us figure out what these implementation approaches could possibly be. The design that we landed on was something called TIPS, or the Trials of Improved Practices. And here we worked with Marcia Griffiths from the Manoff Group and PHC from Pakistan to really figure out how to do this research and ultimately come up with what we refer to as a package of enhanced approaches that focus on counseling and family engagement. For those who aren't that familiar with TIPS, it's essentially a series of visits between the researcher and the participant. So in this case, the participant, in the slide I'm showing here, the participant was the healthcare provider, where the healthcare providers work with the researcher to discuss the current practices. So the researcher sits and watches an ANC session, then discusses the current practices, what could possibly be improved, and sort of negotiate and agree on new practices, or what we call trials, that the healthcare provider is willing to try over the next 4 weeks. The healthcare provider then has a week to try these out, and at the second week point, the researcher goes back in and finds out how did they go. And most importantly, did they like them, and did they make any of their own modifications, which really helps in understanding some of the suitable changes that could be made. They continue to work with these, and then at the end, at week 4, the researcher assessed how the healthcare providers liked the practices, if they were further modified, and if they would continue. What's interesting about the TIPS design that we used is we tried to do something that was more work, probably more complicated, but ended up providing a lot of interesting results, because we did TIPS not just with healthcare providers and these new practices, but also with the other kind of actors in the system. So we talked to pregnant women to hear about, and we did TIPS with pregnant women, we did TIPS with mother-in-laws, with husbands, and with the community leaders. And through this data, we were able to triangulate and really understand how these practices resonated with the different people involved. In interest of time, I'm going to go quickly through this, but I did want to show you an example of a trial, because I think it really brings the TIPS work to life. And one of the things that was coming really clear in the demonstration project in Swabi was that a lot of women were reacting quite a lot to the smell of the actual supplement, the taste of the supplement, and there were some of these things that were starting to come back. And so the interest here was to really address what are some of these practical concerns that are possibly holding women back from taking the tablet daily. And the idea was to try and elicit some of this conversation at that first ANC contact, rather than having the pregnant woman go back home and then realize these things. So the first trial, the healthcare providers were asked if they would be willing to ask the pregnant woman to open the bottle in the ANC contact, to take out the tablet, and to actually look at it. And then there was sort of this next step trial where the women where the healthcare providers were asked if they were willing to ask the women to actually take her first tablet in the session. And I'll remind you that in this case, there was both the community and facility healthcare providers that we were working with. So in some cases, this was women taking the tablet in their own homes. So you can see, if we go back up to the first trial, 47 healthcare providers were offered this trial. 45 agreed to try it out. 43 tried it for 2 weeks, and 36 tried it for a full month. So we had generally very high willingness to continue. And so then this has become part of the enhanced package. You can see it's a little different with what happened with the second trial, where again, the same 47 healthcare providers were offered this, fewer agreed, and you can see it really drops down to the willingness to continue. So this is one that has been disbanded. So going through this kind of TIPS process with these individual trials allowed us to build out what we're calling these enhanced implementation approaches and really try and answer that first question. They fall into really 4 main buckets. One was around improving counseling in general. Then there was this real efforts to improve counseling around getting this message of taking MMS every day. There was a really intentional approach towards strengthening family engagement, that is engaging the mother-in-laws who in many cases were attending the antenatal care session with the women, but then also putting in outreach methods to reach out to the husbands or some of the other influential family members who might be at home. And then working with community leaders, notably religious and political leaders, to further message and reach the husbands around the value of MMS and the importance of ANC. I'm running short on time, so I'm not going to go into great detail here, but I just wanted to point out that we have some similar research that's being undertaken in Nigeria with funding from BMGF. And we're taking that same approach of first doing that switchover from IFA to MMS, and then going deep to explore some adherence solutions. We're working with the government of Nigeria, the government of Bauchi State, and our partner Sonder Collective to use human-centered design to create these adherence solutions. We're at the stage now, we're well into the prototyping, and we're moving forward with trying to finalize some of the adherence solutions, which we'll have available to show later at the beginning of the new year. And with this, I'm going to wrap up. I've given you a couple of examples of where we've listened to voices in the activities that took place in phase 1, with trying to figure out which research questions were going to be of focus. In phase 2, to look at how to co-create those implementations or those adherence solutions. And now I'm going to turn it over to my colleague, Jalal, who's going to talk about how we're going about evaluating those solutions. Thank you.
Yeah, thank you. Thank you, Sarah. While we invite Jalal, I'd like to say just a little introduction. So Jalal is Dr. Chaudhry Jalal. He's the Senior Technical Advisor for Evaluation and Strategic Research at Nutrition International. And his presentation will be around the value of using a combination of different types of evaluation in MMS implementation research to allow for program adaptation and answer important questions for the government. Thank you, Jalal. Please do enlighten us.
Thank you, Jenny and Shabina, and good morning, everybody. So my presentation is on the implementation research. It's just an overview of what we're doing within this project. So you have already seen this slide from Sarah, which actually gives the overview of the time in terms of and how the different evaluations are contextualized within this whole project. So I'm actually going to talk about this circle where it is related to the evaluation of the project. So starting off with the research question. We are trying to see does implementation of the enhanced approach actually improves the adherence of MMS in pregnant women. And if so, how? So this question actually has two components in it, two bigger research questions. One is the evaluation of the effectiveness, the other is evaluation of the process itself. So in terms of the outcome evaluation, we had a cluster randomized control trial, and this is to assess the adherence of MMS. The other one is related to, and we have already done the baseline, and looking forward to the end line after the implementation of the enhanced approach. Then we have the process evaluation, which is a mixed method evaluation of the implementation. And this is going to look at the fidelity of the implementation, trying to see whether or not the implementation is actually following the recommended protocol. And also to see if there is any information that we gather that can be actually used to improve the implementation, and then again to use that information to provide a guidance for scaling up. And no matter how effective an implementation is, or no matter how much we know about the process, it wouldn't make sense without having the cost evaluation done. If the project is not cost effective, it's not going to be sustainable, and there would be no rationale for scaling it up. So we are actually having one cost effectiveness evaluation within this project. I'm going to skip that slide. So in the outcome evaluation, the question is, does implementation research implementation of the enhanced approach increases the pregnant women's adherence to MMS? So we're having this cluster randomized control trial, which is we're using a repeated cross-sectional surveys, which actually involves pregnant women of the same criteria, but in a different samples. So sample size is same. We're using, in the baseline, is a set of sample pregnant women, and then another set of pregnant women with the same criteria at the end when we do the end-line survey. We have 24 clusters, which are the union councils, and within those clusters, we have randomized the intervention and control arms equally. And within those, 70% of the healthcare providers were randomly selected, so that we have the proportionate sampling from the bigger and the smaller union councils. And within those, under each HCP, we selected 5 pregnant women to come to a total sample size of 1,262. And we used pill counters to measure the adherence. Jenny, how about that? Okay. So if you look at the difference that we're going to see, there is a control arm, which is essentially the MMS standard of care, and we layered upon the enhanced approach on that to see whether or not at the end the enhanced approach is actually making any difference. So this is the only difference between the two arms. And so the process evaluation, this is going to be more of a mixed method research, and the key to this is having a program impact pathway development. And this is very specific to the MMS enhanced implementation approach. And then there are participations from different healthcare providers, supervisors, pregnant women for sure, and family members and community leaders, which we have already heard about from the other presentations. And in terms of data collection, we're using in-depth interviews, focus group discussions, ANC observations, and exit interviews. And the focus would be on the MMS coverage and adherence, quality of care in ANC, and acceptability, feasibility, and facilitators and barriers. And all of these are going to actually inform us in terms of how the implementation is going, if there is anything that needs to be tweaked to improve the implementation and find more, better effectiveness. And the data collection is going to be starting from November until January 2024. I just wanted to, before I end, I just wanted to ensure one more thing, which is the evidence that we're generating from these set of research, implementation research, and more particularly from outcome evaluation, the process evaluation, and the cost effectiveness evaluation. These are actually feeding into this project itself, and to improve the quality of implementation as well as the improve the effectiveness of the intervention. But at the same time, this is going to, if you look at the bigger picture, it is going to actually feed into the evidence base so that, the information can be replicated and used elsewhere. So I think I can finish right here in the interest of time, and there are other presentations. Thank you.
So that's the scientist speaking and leading us through the processes which will matter. I'm going to next invite Alison Tomowicz, I hope I'm pronouncing it, who's a senior program officer on the maternal, newborn, and child health discovery and tool team at the Bill and Melinda Gates Foundation. We hope to hear her discussing Bill and Melinda Gates Foundation's increased MMS commitments, coordination, and investments in the coming days. So, Alison, please.
There is a little podium here. I'll stay down. I'd like to cover 4 different topics in the few minutes that I have. The first is I'd really like to highlight the partners and donors who are working in the space, many of which are here, and I might call you out. I'd like to talk a little tiny bit about the 4 areas that we're coordinating. I am going to get up on this podium. Anyway, I feel I can see everybody better. And then I'd like to give a couple specific examples of how we're trying to coordinate together. And I'd like to highlight some other relevant sessions this afternoon to what we're discussing here. First of all, I think, this is the one intervention in nutrition, and maybe because I'm now at the foundation, I can see the huge number of donors and partners and governments that are interested and working towards scaling MMS. And Allison from GMMB is here on behalf of, I think, Co-moderators. We have, so in terms of donors in this space that we're working together with, there's Co-moderators. SIF is also playing a very large role. Eleanor Crook Foundation. I better not forget anybody. Government of Canada, that might be an important one to mention here, and as well as even JBJ Foundation is another one. So there's many. I mean, almost all of the donors in the nutrition space are at this stage coming together around scaling MMS, and also likewise our partners. And I see Dr. Bob Black in the background from Johns Hopkins University in terms of building evidence. Kristen Hurley was here earlier. She is leading various implementation research projects globally. Also, we have, I don't know, you can raise your hand, Phil from ENN in terms of the advocacy space. Shasta Lutter, RTI, just received or was awarded a new USAID project, and we chatted last night about how MMS can be a part of that. So I think the interest is just really incredible. And I couldn't leave out the Micronutrient Forum here. We have Healthy Mothers, Healthy Babies Consortium, the MMS tag. So there's many partners, and we are doing our best to align and coordinate, but the commitment is really huge right now, and I think that's just really encouraging. Practically brought me to tears at a UNICEF meeting some months ago, because it's not you don't always have that, and I'm hoping that we can ride that momentum together. Areas that we're trying to coordinate together, I see 4 main do I have 4? Yeah. I have 4 main areas, particularly that the foundation is aiming to work together, and we have a role, I think, to play with governments to support. One is the evidence piece, and this is what we've heard a lot about here today, the importance of governments having the evidence that they need to make policy decisions, and as the donors, we're trying to support that, that process. And then the second is the groundwork that needs to happen to introduce a new intervention or to bridge delivery gaps in the country. And we talked about changing protocols, getting MMS on the essential medicines list, the beautiful branding and signs and change you have in Pakistan, the video that you produced, all of that is necessary and takes resources. And as donors, we're trying to coordinate, align, and support the key stakeholder groups that are coming together in country, and of course, the importance of supporting the government to be the leaders in that. The third area that we're working together is to increase financing and resources. I think for the government of Pakistan is really, I don't want to misspeak, but to my knowledge, it's one of the only governments that has already, is committing resources towards MMS, and that's just so important. And so working towards getting MMS into national Ministry of Health budgets, but also working together with donors to make sure that there's, also donor funding going towards maternal nutrition more broadly, and MMS as a part of that. And I do want to mention one. Well, I guess I'll mention that in my next section. But anyway, the fourth area that we're working on is the accessibility of the product itself and lowering the cost of that. We've come a really far way really, in part, thanks to Kirk Humanitarian for showing that we can reduce the price of MMS significantly, and working with companies to do that. Those are the kind of partnerships we need. UNICEF is also making great strides with their suppliers to figure out how we can lower the cost of the packaging and the product itself, and the the ingredients that go into it, so that, and how we can do it for local production in countries that have the capacity and desire to do so. So all of that's another area where all of us are trying to come together and support moving forward. So just to mention a couple more examples and how we're coordinating, I did mention the MMS tag, and that has been an incredibly important and coordinating, committed group that has tirelessly addressed evidence questions that has come up through through developing global guidance, as well as now directly to countries, and as donors and partners, we're supporting that. Another specific example that I want to highlight here, and for you all to also bring back to in the countries and the governments you work with, is the Child Nutrition Fund. It was set up by coordination between several donors, particularly SIF and the foundation ECF. And what it does is provide a one-to-one match when a government procures MMS through the UNICEF procurement process, and so the governments can help get a foothold to introduce MMS in the product, and also stimulate demand, and hopefully have that self-reinforcing process in terms of supply and demand. So that's another way that the donors we've all come together. And then maybe just lastly, this is not the first product we've tried to introduce and scale in the nutrition space. Many of us have been around for MNPs. We have KDUI for SQLNS. This is a pathway that is well worn, but we haven't had exactly the success we want. I mean, IFA is very available, but we have problems with quality, and then we've seen the problems with adherence, and so we do have a lot of challenges to still surmount, but there are some really important lessons learned from introducing RUTF and community-based acute malnutrition, introducing MNPs. Hopefully we're going to go on that same road with SQLNS to try to move that. And so MMS it's different, but no different in that respect. And so later this morning, there is a session on the lessons learned from scaling, implementation and scaling of home fortification interventions. I think that session is really relevant. We need to do some self-reflection in the nutrition community about what's worked and what hasn't. And then later this afternoon at 5:30, there's another session on what's needed to support scale and sustain micronutrient supplement interventions. And I think that's another session that's particularly relevant for this conversation. So happy to answer questions afterwards, but thank you.
Thank you, Alison. Giving us hope and raising our hope and telling us all the positives. Yep.
We're just getting the slides up. We do want to leave some time for questions, so I'm going to jump through some slides here so we do have some time, because we've got a number of people online as well. So this session here was, and I'll make this quick, it's really learning from program experience and adopting e-tools for greater success. And I think, as Alison said, we need to learn from what we already have. Don't repeat our same mistakes, but build on the successes as well. We started the morning off with a bit of an exercise looking at the Lancet series over the number of years of 2008, 13 and 21. And really the takeaway was that we have a massive unfinished agenda. So how do we deliver at scale what we know works? And there has been, in this last Lancet series, a real call to action on improving program effectiveness, but investing in implementation research to help us get there. And as WHO recognised the long-standing issues with iron and folic acid supplementation, when they made the update to the MMS recommendation in 2020, called for implementation research, rigorous research, as you think about that transition. We talked about the adherence gap and how we need to close this adherence gap, and it's one of the major areas of focus for implementation research because it is a concern of many of the countries. I think what we heard too is when we don't have MMS necessary in the field right now, and introducing a new commodity comes with complexity, and I don't think we should undermine what it takes to switch out one product for the other. And we really have to look for the opportunities and the challenges, thinking about the delivery platform, which is largely ANC, and we know this is often weak. The supply, the logistics, the operational guidelines and policies, and how do you embed this preventative supplementation alongside identification and a treatment of anemia, which is currently mostly IFA. We heard about how it is important not to go beyond the facility and engage family members, the decision makers, who is helping to make that decision for women to be able to adhere to supplements. And this is one intervention of many in the ANC guidelines. We have about 49 recommendations, so we have to be careful that we're not too vertical and undermine the other interventions that are going to progress maternal and newborn health. I just quickly wanted to bring your attention. There's a leaflet at the desk that tells you a bit more about some of the tools we have. This is a busy slide, but it really is, Nutrition International works alongside government, as you've heard, but we've been working in the maternal nutrition space for almost 2 decades, and particularly focusing on iron and folic acid supplementation for pregnant women to strengthen that. And so in that journey, we've really tried to unpack, program pathways, what does it take to drive adherence, the interconnectivity between different activities. So this is one of the tools that we have, and this slide here, I mean, the message here is there's a lot that goes together to drive adherence for a woman to take a supplement to then see those global nutrition targets that we've committed to. So what we've done, when we've presented this a number of times, people have asked for more of the tools, more of the know-how. So we developed this free online course, which was launched during COVID in 2021. This is available on our website. There's a one page at the back of the room if you haven't got it. It gives you more information. This course, it's really targeted for program planners and national and subnational governments. It has 7 units. It's roughly less than 6 hours to complete the tool, but it's a one-stop shop with all guidance and tools and links to other partners' works as well. The topics covered in the tool, it talks about maternal anemia, the power of maternal nutrition, and what it can do to move the needle, with a big focus on MMS and IFA, but then tools of helping governments, and this takes from our learnings where we saw quite a big jump in adherence to IFA when all of these things came together. So trying to share the learnings as we go through into the MMS space and give you those tools. There's tools on how to do a sex and gender-based analysis. There's our MMS cost-benefit tool. It's all in one place, and we've had great feedback from the users already on the course. This is a little bit more showing you the tools. The other thing that it does, it allows the user to really assess where they are in the journey, not just the importance of having a policy, but what's in your policy, what's missing, what are the gaps. And then, of course, in this course also it references our MMS cost-benefit tool, which is also on our website and free to use. There's also some policy briefs. Feel free to take any of the examples at the back of the room that you see here. We've got policy briefs for 34 countries now that go along those tools, and this has been presented previously. So just looking ahead about the transition and scale-up of MMS, please use the tools that are already available that have drawn from the knowledge and the experience of iron and folic acid supplementation. Of course, our cost-benefit tool, it's one of the major questions that governments ask, is switching to MMS better value than IFA? More to come. We are now looking at the transition costs and developing methodologies to capture that changeover and what it costs in terms of updating materials and building capacity for frontline health workers. That is yet to come. And then, of course, today you've heard some of the work that's going on in Nigeria and Pakistan and our learnings that will come out of that. So that's all from me, and I wanted to cut that a little bit shorter so we can have some time for questions and answers. So if you have any questions, please come to the microphone. We'll take some in the room, and people online, please post your questions in the chat. We'll also respond to those as much as possible, and we have roughly probably 5 minutes. Thank you. Go ahead.
Yeah, thank you very much, all the speakers, for really inspiring presentations and experience sharing. I think it's a lot of learning for some of the countries who want to replace IFAS with MMS or try to implement operational research. My name is Samson. I'm from UNICEF Rwanda, and Rwanda is one of the countries who is trying to replace IFAS with MMS, and we are on the way, moving forward, learning from you. So my few questions is, one, I'm wondering if there is a standardized monitoring framework developed to see consistency across implementation research for comparability purpose, but also to guide new implementation researches in the right track on the issues that needs to be monitored and evaluated across the implementation period, or if there is any progress in standardizing monitoring framework that we can learn or adapt from implementation researches that had already been done. My second question is, especially for Pakistan in your implementation, how did you manage packaging or dose vis-a-vis the need to strengthen maternal health and nutrition using MMS, which includes strengthening antenatal care follow-up, at least 4 times or 8 times follow-up, monitoring of fetal growth or pregnant weight gain monitoring, and also at least addressing adherence gap. So how was it? Because we know the bottle is 180 taps, 6 months dose or package, and then once it is given, how could we get the mothers coming back and monitor all these important elements of programming, but also ensuring that the MMS is strengthening the antenatal care, or otherwise we just give and we might weaken the maternal health and nutrition program by keeping the mothers away from the health system, giving a 6 months dosage of MMS tablets. Thank you.
Before we answer, I think just because we're short on time, can we quickly take the other questions and then we'll try and group, and then if we've run out of time, we'll be here at the end as well. So if you could just be the other two, if you could just do quickly your questions and then we'll try and respond all together. Thank you.
Okay, thank you very much. My name is Charity Shandaziva. I'm a nutrition specialist with UNICEF. My question is directed to Pakistan. I feel the subject of MMS addressing anemia is at the heart of most people that are working in the nutrition field. And I feel that sometimes we are talking to ourselves. I just wanted to understand, how did Pakistan engage other health departments like the nursing, reproductive health? Because when we talk to the other colleagues, they'll tell you that the antenatal care platform is already weak. We are overwhelmed. There is nobody taking blood pressure and all that. And here we are trying to say, can you take on board the MMS? So I just wanted to understand, how did Pakistan go around that issue? Thank you.
Yeah, thank you. Chessa Letter, Arte International. 2 questions. The first presentation, Jennifer, I think yours, and then we also saw from Dr. Chadberry that procurement and supply were huge issues. And this is what I saw throughout my career for 20 years in working with governments in Central and South America with respect to procurement in general. And yet, you know, the very comprehensive and interesting process you went through to really identify your implementation research questions, there was, to me, just huge disconnect between all this work being done at the clinic level on adherence and when we're seeing, at least I'm hearing and I've seen, the issues with procurement and supply. So I'm just curious how you're going to actually look at that. Is there a plan in place in Pakistan to be sure you've got the procurement, at least for the first couple years? My second question is related, and that is, Allison, you said, this is different, but not that different. And in some ways, I see it as very different in the sense, and somebody also alluded to this, there's already a market for this stuff. This stuff exists on the shelf. I don't think it's not a foreign concept, I wouldn't think, to the women in Pakistan or in other countries where we work. And so is there also discussion and thinking going on right now? How do we also just make this available on the market? Because then it's just not a matter of donor and government funding, but in fact, a lot of women that are going to fall through the cracks or have the money will just get it themselves. Thank you.
Thank you very much. This is Shadrach from Kenya. My question has actually been asked, but I just wanted to maybe kind of rephrase it. And thank you very much. I think one of the speakers said that we have gone this road before. Personally, I've worked with the MNPs, I've worked with LNS and other products, and I'm now seeing this product coming in. I think we need to draw from the lessons we've learned from the previous products that we have introduced. And that's very critical. And not only the nutrition products, because we have also learned a lot from other health products, including the HPV vaccine, the introduction, the misconceptions that come out from the community. One thing that I'm not seeing, I'm not seeing a lot of discussion on the demand side of things, on the mothers, more information on the mothers. How are we going to approach the mothers and the communities to convince them that this is a good product? This is a product that needs to be taken up very quickly, given the challenges that we've had with IFS and given that we are replacing it. I don't know, maybe this is not the right fora, but are we also thinking about the social behavior change communication strategies? That is something that we will need to think about. Maybe we are still focusing on the initial, high-level issues, but at the end of the day, we will not avoid going to the community and really influencing the mothers. And I think very robust SBCC strategies will be needed. Thank you.
Do you want to do monitoring? I think we've got a number of questions here, and we'll do, we heard about the monitoring framework, but lots of questions for you, Dr. Khwaja, on the platform, the strength of ANC, making sure women come back to ANC, demand versus supply, a really good question. We can talk a bit about that. So, Dr. Khwaja, would you like to speak on the
Thank you. Basically, the strategy as well as the government policy was that we would be using this MMS for the strengthening of ANC. The issue that we have is that usually ANC is not being recognized or taken as a process. Usually women come only when it is late second trimester or the early third trimester, when they start feeling some complaints or some issues, and then when they want to know what they are going to do for the delivery and all these things. So one of the reasons of this MMS was that they can come to the ANC, and is not was. So that is why when we were doing the pilot, we supplied these MMS to the health facilities only. We did not give it to the community health workers, and we just asked the community health workers that they should bring or they should refer the pregnant ladies to the ANC, and the pilot was successful, and the same is being done in the implementation research. Of course, when we had to supply in the humanitarian context, which I showed, then all the formal procedures were bypassed and the community distribution was done. And this is one. We are trying to strengthen, and fortunately there has been improvement. The 4+ visits have increased from 40% something to almost 80% in the last decade. So this is all because of that social and behavior change through the LHWs as well as the involvement of the private sector, which I said. And we have also, so I will be clubbing both the questions. We have also recently developed the SBCC strategy for maternal nutrition, and which specifically focus on the awareness creation. We are using not only the social media, but also the mainstream government electronic media to create awareness about the maternal nutrition and why ANC and the supplements are important. There was a question about the already availability on the shelf. Definitely, I mentioned it myself, but there are different formulations, and usually the composition also varies. So for that, we have already, because as most of the people know, that we are producing RUTF, RUCA, SF, MQLNS within country, some for the last 15 years and the others for the last 2 to 3 years, and we're also working to produce SQLNS also. So similarly, simultaneously, yes, for the first year and a half, we have donation thanks to Turk Humanitarian, and they have pledged that they would give us donation. Part of that donation already reached, which we distributed, and the remaining would reach very soon. So for the first year, we do have the commitment by the donors. Already, Alison mentioned that one of our largest province has ordered UNICEF to procure for the, so government is also allocating resources, and we are also working with the other partners for the fund generation for the overall nutrition programming. And when it's overall nutrition programming, MMS is the part of it. And for the local production, we are in connection through the UNICEF procurement division in Pakistan, communicating with the different pharmaceutical firms. And one of them started work last year, and they are in the final trial stages, and maybe they started. And we are also trying to persuade other global manufacturers that if they cannot manufacture immediately, they should have some collaboration with the local pharmaceutical firms for the import. Government of Pakistan is very supported in exemption of taxes and duties, and we have done it for many products, and already the raw material of multi-micronutrient supplements is exempted. So when the local production starts, it's much cheaper than the one that we are importing. I think this answers most of the questions related to ANC.
Maybe in 1 minute, can we talk about the monitoring? Sarah, do you want to start with them? This is a big, big journey.
Yeah, the monitoring is tricky. In SWABI, what we really needed to do, and there's actually been changes since we began this, because there's been a lot of work on DHIS2 in Pakistan, which is actually going to include the indicators that we're looking at, that we need for MMS, and to be able to monitor MMS itself. But part of that health worker training was really working with the health workers when they were filling out their tally sheets to make sure in the spot where they would normally be filling out for IFA, during this sort of demonstration period, to tick it off if they were handing out MMS, so that at least then when the government was looking back to see around, whether iron and folic acid containing supplements were handed out during that period of time, you're not going to have this big blank spot. But we also had sort of a parallel reporting system that's happening, where there is a sheet that the health workers are asked to fill out, where it does indicate, because the indicators that are within the existing HMIS were quite limited. And so it really did, we had a monitoring system set up so that they would tick off whether or not they gave the bottle of MMS or IFA, how far along in the pregnancy the woman was, and we actually did record the woman's name and the address so that there could be some further follow-up, which was done as part of in the part of the evaluations. And so we have somebody who's paid for by Nutrition International that actually sits in the district health office as a data officer, and helps to compile and really kind of hunt out some of these reports that aren't coming through, because most of them it's quite impressive to see the reports that are coming through from the facilities and from the lady health workers. And then he goes and tracks the missing ones, and compiles them into this database. And this database is fascinating, and I think it's a really rich repository where you can start to see some other trends. And it's actually, this monitoring data that really gave us more information that we're looking into deeper in the process evaluation around what's working with this transition, and then the areas that we really have questions around what's not working. So I'm happy to answer further questions on this afterwards too.
And yeah, please come forward and ask questions to individuals. I think we've run out of time. I know the next session has to set up, but I think just building on that, the tools for knowing how to do implementation research, what is implementation research, what does this WHO guidance, I think it's a question that's been asked by many countries, and there is a working group at the global level who is hearing this and is working on developing tools under the Healthy Mothers, Healthy Babies. There's a technical working group. So there's more to come on that, and hopefully more guidance to help you. So I just want to say thank you to all the speakers. Thank you for coming out so early in the morning. We'll be around for the next few days if you need to ask any more questions. We also have the resources at the back. So thank you very much, everybody.